Welcome to the True Sports Physical Therapy Podcast. We got Dr. Mary Miller here, multi-site manager at True Sports Physical Therapy. She now runs the hell out of Fells Point location as well as Locust Point. Mary, welcome to the pod.
Thanks for having me.
You are a running expert. You love rehabbing the running athlete. I'm going to love this conversation because I hate rehabbing the running athlete, and I know very little about it. And what I do know, you have taught me in the last 6 or 7 years, I would say. So this is a population that I personally struggle with because they're awesome for 10 miles, but the 11th mile is a problem or the 23rd mile is a problem. And so that's always hard for me to analyze how it is that an athlete is having symptoms that far in to their sport. How do you go about just assessing an elite level runner like that?
Certainly. So I think importantly, when we assess the elite runner, is that we have to push the boundaries on that assessment. So we have to be doing things like plyometrics, drop downs off of a really high box, things like that, as long as somebody is not having symptoms of bone stress injury, of course, but pushing the envelope a little bit so that you're really exposing the weaknesses that you're not going to see in just normal everyday activities.
Okay, so you just try to ramp things up inside of the assessment.
Yep.
How would you say your assessment or evaluation of this athlete has changed over the years? How long have you been a PT?
I've been a PT for 20 years.
Okay, so how is your evaluation different in year 20 than it was in, say, year 15?
Right. So, I mean, I think really in the past 10 years it's changed drastically in that I'm much more delving into the functional movement assessment, the ability to absorb shock and produce power, things like that on the assessment for the runner.
How do you do that? Because that's just sounds challenging. Break that down for me.
Yeah. So, I mean, it kind of going through almost like the FMS of runners, right? So having them squat on one leg, having them balance on one leg, having them do one-legged bridges. So a lot of one-legged stuff because runners are spending their whole entire time of their sport on one leg. And then I, as long as they're clearing all of that, then I get them onto a box. I have them drop off. I'll have them drop off, land on one leg. I'll have them jump over a hurdle with 2 legs, jump over a hurdle with 1 leg, and then kind of put it all together, have them drop off and then jump over that hurdle. So absorbing the shock and immediately producing the power again.
Okay, so that's all on evaluation. How is that different than, say, 10 years ago?
So 10 years ago, I was more fresh out of school. I was doing much more your table strength test, manual muscle testing, basic range of motion testing, really not doing as much in weight bearing on the assessment when I first came out of school. And then now it's pretty much all off the table.
And off the table, are you looking for symptom provocation or you're looking for quality of movement?
A little bit of both. So, I mean, it depends on the patient in front of me. If it's somebody who's having, say, some hip discomfort, I'm looking what's their control like when they're landing on that one leg. But I'm also seeing if they have pain with it. Sure.
Okay. So what else are you looking for when you talk about qualitative assessment there?
Yeah, I get real nitpicky because these guys, like you said, it's happening later on in the mileage. And so I'm being really finicky when I'm looking at them on one-legged squat or their box jump or drop down to really nitpick, are they dropping into dynamic valgus at the knee? If they're not, what are they doing at the trunk? Do they laterally lean at the trunk? Do they get a pelvic drop? Getting really picky on that. What's their balance like when they immediately land? Can they control that? Yeah.
And so is there any thought that these athletes, maybe they're not having pain till later in their runs? Do you pre-fatigue them? Do you do higher reps, let's say, in the evaluation?
If it's somebody who's really, if it really is coming on later in the race, then I could have them. So on initial eval, I'm not going to know that, right? If somebody's just walking through my door, direct access, they're just going to come in. If I'm lucky, maybe they went for a run before they saw me, but maybe the second visit that they come in, I'll have them go for, if it is somebody whose the symptoms aren't there until later in the run, I'll have them go for a run first before they come in.
Okay. So they go for a run, they come in, and then you're doing these maybe high repetitions, depending upon what is symptomatic. How much import do you place on the form of, let's say, that drop down test versus the symptoms?
I think the form gives us a clue as to what they're going to look like when they're running. And so day one, when somebody comes to me, I usually don't have enough time to do the video assessment of somebody running. So that usually comes day two, unless I'm lucky and I have a little bit extra time.
Okay.
So that first assessment of quality of movement gives me a clue as to how they're going to look when they're running. And running is running injuries are repetitive injuries. And so what's that quality of movement? What's happening repeatedly over and over and over again when they run? And that's going to give me a clue as to what structure is
at fault.
beat up.
Okay. Okay. That makes sense. So if your evaluation of the runner 10 years ago, you had him on the table, you're doing a bunch of manual muscle testing, I have to believe most of your interventions were, they have weak hips,
Right.
so we're going to give them clamshells, or maybe they have weak core and we're going to teach them dead bug. How is it different now?
Difference now is, you're still going to have that strengthening component, right? I still want to strengthen those hips. I still want to strengthen the core. I want to strengthen muscles that are getting used repetitively. A ton of runners have weak hip flexors, and hip flexor is the only muscle that activates concentrically, and that's during the swing phase. So really loading up muscles in a more functional pattern than I used to probably. And so that's going to happen. But I also know that strengthening alone is not going to change how they run. And so I have to educate the body as well and do drills and follow up with things like that to really hit home what the movement pattern fault was and try to correct that movement fault.
Okay, so let's put a pin in that, because I want to make sure we come back to that, how you teach running form and how you get that ingrained and whether that can be actually changed, and how to change that. But I want to touch on range of motion, because so far functional tests that you just described, we're not necessarily going to see a lack of range of motion. So when does that come into your evaluation?
The biggest range of motion that I find to be the most valuable is going to be ankle dorsiflexion. And I measure that in a weight bearing position. So I do that in half kneeling, and I have them drive that knee forward. I use an inclinometer on my phone to actually measure what the shin angle is as it comes forward over the toes.
And so you put your phone where?
Along the spine of the tibia.
Same spot every time?
Yep.
Where is that? Where do you put it?
No, directly.
How far?
Right at the top by tibial tuberosity. And
Okay.
Yeah, so I have my phone resting on the tibia there.
Okay, so you put it on tibial tuberosity, and you're looking for how much, should we call it inclination?
Yep.
How much inclination transpires at the shin or the tibia. What's normal?
Normal is 40 to 45. That's what you need as a runner to be able to come directly bring that knee over your toes. If you don't have that mobility in your ankle, then you need to find it someplace else, right? So if our ankle only moves 30 degrees or if the tibia only moves 30 degrees forward, now we have to pronate the foot. Now we have to go into dynamic valgus to get that knee to progress forward over the foot.
Okay. I thought when you said classic ranges of motion that are lacking, I thought you were going to say hip extension. But you went with dorsiflexion. Do you test anything on the table?
So I will test hip extension to
Okay.
see what active is, and then I'll passively move them to see what they have available to them. And if somebody's hip, I'm gonna see what their hip rotation is like, because a lot of runners are getting into some impingement with that repetitive forces through it.
Okay, so you're looking at active range of motion, you're comparing it to passive range of motion. What should the discrepancy be?
So I want a runner to have, ideally in a wonderful world, they would have 10 degrees of active range of motion, and hopefully I can get them to 20.
You use a goniometer for that? Use your 20-year trained eyeballs for that.
I'm using my eyeballs.
Okay.
Yeah.
Okay. So if something's stark,
Yeah.
then you come up with some type of intervention to address that. Then you're looking at tibial, we'll call it dorsiflexion. You're looking at dorsiflexion using your inclinometer. Any other ranges of motion that are imperative or a piece of your assessment?
Those are the big ones. I mean, certainly if I had somebody post ACL, I want to make sure that they're able to get into full knee extension, right? I think I want to see the quality of that knee range of motion on somebody who's post-op knee.
Okay.
If they're not post-op knee, I'm really not looking at their knee range, because most people are going to have normal ranges unless
Okay.
they were post-op.
Okay, even if it's patellar tendonitis?
Patellar tendonitis, I might check like in prone line to see what the rectus femoris length is like. But that's not my first go-to.
Okay, what are you looking at in prone? You're looking at knee flexion?
Knee flexion, yeah.
Okay, but you don't address knee extension. You're not worried about some type of lag with patellar tendonitis?
Not necessarily, no.
Okay.
I feel patellar tendonitis, I think what you're getting a lot of for runners, and that is patellar femoral pain is the most common site of running pain related injuries, right? But it's pretty linked into that ankle dorsiflexion, that dynamic valgus, that plays a huge role into it.
Okay,
Yeah.
and usually you'll trace back up to the hip to address that?
Trace it to hip or down below, right?
Okay.
Or to the ankle, foot
Okay.
ankle.
How much quad loading do you use as an intervention, or quad strengthening?
Sure. If somebody has that patellofemoral pain, I'm doing some knees over toes squats, things like that, in that situation.
Are you testing quad strength?
Manual muscle testing, I feel most people, if I test that, it's going to be strong.
Correct.
So-
right. Have you thought about using a TIN-DEC, or is there some type of measurement that you would love to use?
So TIN-DEC would be helpful in that situation if I don't know, like, yeah, if you think that that's lacking. I just find that with these guys, unless it's somebody who's post-op, it tends not to be the most blaring weakness.
Okay. So let's say they're at 30 degrees of dorsiflexion. You want them at 40 to 45, you said, right?
Yep.
What's your strategy there to impart a change in dorsiflexion?
Change in dorsiflexion. Certainly, I'm going to let them do their normal stretches, but I'm also going to have them do self ankle mobilization. So I have a lot of my patients buy pull-up assist bands and use that in a half kneel position to get the proper glide of the talus posteriorly by using that band.
Okay. So, and how do you dose that?
I have them kind of pulse into it. So I have them get that like rhythmic oscillation of the joint to try to loosen it up, get some synovial fluid going. And usually I'm having them do it maybe 3 to 5 sets of 20 to 30 pulses. Yeah.
Okay. And why do you think that dorsiflexion is such a pervasive issue in this population?
Runners don't stretch.
They don't stretch, but you wish they would.
Sure. And I say that as a runner who doesn't stretch.
Okay. Okay. So you wish they would do more of that. So by giving them that stretch, or at least that mobility, okay, that would help. I'm getting towards footwear,
Mm-hmm.
and how big of a part that plays in, let's say, pathology.
Mm-hmm.
Runner comes in, they're a novice, they're training for a marathon. They say, Dr. Mary, you're the expert. You work at an outstanding practice. What footwear would you recommend that I wear?
So the first thing I tell patients is wear the shoe that's most comfortable to you. So that's the biggest thing, because every running shoe has a different last to it. That's how they're forming the shoe around, like what the model foot is that they're forming the shoe around. So you want a shoe that actually fits your foot type. After that, I tend not to go into, oh, you need stability, or, oh, you need to go minimalist, because everybody's a little bit different and what's going to be comfortable to them. And I have yet to see, and don't tell any of my friends at the running store, but I have yet to see a stability shoe that actually improves the function of the foot. If it's somebody who has plantar fasciitis, then I'm going to recommend maybe some inserts, some over-the-counter orthotic insoles to put into their shoe to help give their plantar fascia a little bit of rest. I'm going to be wary of somebody who has Achilles tendonitis or any lower limb, like Achilles tendonitis, plantar fasciitis, things like that. I'm going to be wary of putting them in a minimalist shoe, because that's going to increase the work needed from those structures. I'm going to know that somebody who has knee pain is actually going to feel better in a more high cushion shoe. So like if I'm looking at diagnosis, I might, if it's a novice runner, say, hey, you'd probably do better with this type of shoe versus your flat shoe.
Okay, and what do you recommend? They go to the shoe store, they go to the running store, and they try them on, and they get on the treadmill.
Yeah, absolutely. So most of our running stores around here have treadmills in the store. We have one that doesn't, but they'll let you run around the store in it. That's fine. And yeah, try on a bunch of different shoes, see what feels most comfortable to you. And oftentimes when I send somebody to the running store, I'll write down a little note and have them give it to the salesperson, because a lot of the sales folks there are pretty well versed in the different types of shoes that they have available and what might feel comfortable to that patient.
Yeah, I think that makes a lot of sense. I get a little leery of giving so much, I don't know, power or autonomy to the salesperson, because I think there's a whole background to that where it's like, hey, we're going to carry Brooks as an example. You're going to push this shoe because we need to bring up sales. Is there any truth behind that?
I don't think so, because they all carry a wide array of shoes. I do think we sometimes get stuck in the new shoe that's out, the new, like the new popular type of shoe,
Yeah.
right? So right now, especially for folks who want to be fast, it's going to be your carbon plated, high cushion shoes, max cushion, super max.
This is the Hoka world.
No, this is your Nike Alpha Flies and
Okay.
all that stuff, like the really, really beefed up ones for your marathon runners who are really competitive. So that's really popular right now, and they're making training shoes that have carbon plates in them, things like that. I tend to stay away from the trends. Especially for somebody who's new to running.
Because I feel like 10 years ago or so, it was all about barefoot, right? Like, let's get as minimalist as possible, right? And so we just kind of bounce back and forth. So your antidote to that is find what's comfortable to you, okay, and start living in that. Now, if they go, hey, I'm way more comfortable when I'm walking around with clouds on my feet, do you want to progress them, like increase their, let's say, intrinsic strength or gastrocnemius complex strength and get them to minimally?
Not necessarily. So I'll have people exercising in the clinic barefoot. I do that a lot. I want to build that intrinsic strength in the foot and ankle, but I'm not necessarily using that as a tool to get them into a lower profile shoe. I'm okay with them being in whatever shoe is comfortable, and there's a lot of training that needs to be done if you're switching from one type of shoe to another, and not enough people train properly to do that. And so you do find where somebody might go down to a minimalist and now all of a sudden they're ending up with metatarsal pain, right?
Yep.
Because they haven't worked their foot that way. So I don't think it's necessary. The other thing is minimalist. The big thing was, go minimalist, and now you're going to be a 4-foot runner.
Yep.
That also didn't happen, right? The shoe Newton kind of proved that to us. We're going to put lugs underneath the 4-foot, and we're going to have everybody landing on their 4-foot. It's going to be great, and everybody's going to have happy knees, which was the ideal. But they put the lugs there, and everybody still landed on their heel.
And so they still had knee pain.
Sure.
Okay. And so that didn't help. Okay. True Sports Physical Therapy is growing like wildfire. We have 14 locations, soon to be more. We are throughout the state of Maryland. We're in Pennsylvania, in Lebanon and York, Pennsylvania, as well as in Delaware, in Newark and Wilmington, Delaware. Like I said, so many more practices to come. And we always need outstanding sports physical therapists. Our treatment style is unique. We are one-on-one with your athlete for 45 minutes every single session. You do the entire treatment. You do the entire evaluation. And they are in state-of-the-art facilities where you have room to run, throw, and jump and really get your athlete all the way back to on the field and better and stronger than they were. We also have outstanding salaries, comp structures, bonus abilities, 401ks, as well as a very strong continuing education offering, including in-house continuing education. And we're looking for you. Now is the time, as we are growing like crazy. Just shoot your resume over to Yoni, Y-O-N-I, at True Sports PT, or shoot us a DM and we will hit you back. We will get you in for our unique, tried and true interview process and really make a determination that this is the right place for you to grow your career and get your athletes better than ever. We can't wait to hear from you. So then you hinted at it previously, which was how to change the runner's form. Mm-hmm. Now, I live in the baseball world more so than the running world, and one of the last things I'm touching is a pitcher's delivery and form. when do you make the decision, hey, I'm going to teach you how to run? And then when you do make that decision, how the hell do you teach them how to run?
So for me, it depends a lot on where they are in their training cycle. So I get a lot of runners come through my door. It's the end of training season. They've got 1 month until their race, and they're feeling pain and they want to feel better, and they just got to get through this race. I am not touching their form because it's just going to be too much mental energy to put forth to be able to run that race with a new form. They're going to have to think way too much. It's going to be very unpleasant.
So you're not touching it. When do you touch it?
So if they come to me and it's off season, if they've just gotten through their race is done, they're having pain because they just ran 26.2 miles
incorrectly.
Yeah. And they come in and I'm like, okay, well, let's get you feeling a little bit better. And then depending on how bad the pain is, I'll get you feeling better. Then I'm going to get you on the treadmill. I'm going to watch you run. And then we're going to start doing drills to help you become more efficient and develop slightly better patterns.
Okay. So your first intervention there, what's the first thing you think about changing or improving?
So some of the biggest things that we're going to see with running gait is overstriding, right? I've talked to you a lot about that.
Yes, I'm a big overstrider. Yes.
So overstriding is probably one of the easiest things for a runner to fix, and it takes least mental energy to do so.
Tell me why that's such a problem when one overstrides. And before you do that, define overstriding.
So overstriding is when your foot is landing in front of your body and you have higher braking forces. So your foot is angled upward, your knee is straight, and you're hitting that ground pretty heavy on the heel in front of your body. And when that happens, you have to accelerate your body to get over your foot, and that acceleration of the tibia causes stress on those anterior structures. So you're looking at shin splints, you're looking at patellar tendon pain, anything like that. So correcting that is really important to help, especially with somebody who's like getting the shin splints and stuff.
Okay, so you're videoing them and showing them, or you're seeing, hey, you're overstriding.
No, never seeing with your bare eyes, because your bare eyes are going to fool you every single time. I have plenty of people that I watch run on the treadmill and I'm videoing them and I'm thinking, oh, they don't look that bad. They're landing with a bent knee. They're doing pretty good. And then I slow it down and they are overstriding. They're landing on that straight knee, foot way up in the air. And it's just happening so fast. You cannot see it with your bare eyes.
Okay, by the way, same thing with pitching.
Yep.
Like we think things look good, but things are moving too fast. So you got to video them and slow them down. Okay.
Yeah.
So that's why I have some success in the running world. Okay, so when that happens, what do you do?
So I get that information. So now I'm counting how many steps per minute they're taking. And what's kind of nice is a lot of people, if they wear their Garmin watches or some of the other smart watches out there, I like Garmin, but when they wear those watches, it gives them a pretty accurate step rate count for their cadence. I find out what that is. In an ideal world, they're at 170 or above. That number is going to fluctuate a little bit depending on somebody's height, right? But they really found that the lower your step rate is under 170, the higher your risk of injury.
The lower it is. So you want them 170 and above.
And above.
Okay. How do you coach them? Do you just jump to 170 if they're at 110? Okay, what do you do?
Yeah, so if somebody comes in, they're 150, let's say, and I've had that. So they come in, they're 150, I increase it by 5%. Because more than 5%, the mind just can't wrap its head around it. It's just too much of a jump.
And how do you train? How do you teach them that?
So you start off with having them run to the metronome the whole entire time they're running. And you're looking at like 20-minute runs probably, right? And then as they go, you gradually take that feedback away. So you tell them, okay, you're going to play the metronome for a couple minutes, then you're going to back off for a couple minutes, then you're going to turn it back on, and you kind of go back and forth with this feedback. And then you gradually wean it down so to the point where they just listen to it for a minute when they start and a minute when they end. After 2 weeks, like if they run 4 times a week like that, after 2 weeks, they should have a new cadence.
That becomes their natural cadence. They don't have to think about it. Okay, so that takes 2 weeks. And how far do you push them? If you're moving them up 5%, do Do you want to keep pushing until they get to 170?
Ideally, yeah. If I have somebody that's that low and they're overstriding that much, I'm probably, unless there's somebody who's really tall, I'm still pushing it so that I get them to the 170 or above.
Okay, so you keep reminding them, and then when they come into therapy, maybe you do a review of that on treadmill, and then what therapeutic exercise?
I have them do drills to the metronome, right? So I have people march up and down our clinic incessantly with the metronome running. I have them do ladder drills to it. I sometimes have them do wall drills to it. Just getting them used to getting their feet off the ground that quickly in a running pattern. I love the marching because the marching they can still focus on that knee coming forward as well.
Yeah.
And so that's really nice to slow it down.
Do you do your plyo stuff to that cadence? Like, will you have them do multiple box jumps at that cadence?
I'll have them do more the one-legged squat. So I'll have them do a one-legged squat to half the cadence or half the set the metronome to half the cadence, right? So that
that's smart.
So that it's looking at that ability to go down. And it's not a full one-legged squat. We're not talking pistol squats. We're talking a runner goes to about 40 degrees of knee flexion at mid stance and then comes back up. And so I'm just looking for them to hit 40 and come back up. And I'm looking for them to be able to do that repetitively to the metronome.
Okay. That's a ton of awesome tidbits. And I love that you've kind of moved away from the way you used to treat 10 years ago and are continuing to progress. Talk to me about instrument assisted soft tissue mobilization, as you would say. How long has that been in your practice? When do you use it? How do you know who needs it?
I still use it a ton.
Okay.
So I was trained on it a long time ago. And I was trained under a company called ASTEM. And so I use it pretty much with anyone who's having muscular tendon pain if it's chronic in nature. So as long as they're not in an acute inflammatory state, I'm going to use it. I find that getting that blood flow to the muscle tendon unit, when I do that treatment, I'm running the tools parallel to the way the fibers are running underneath. I'm not going cross fiber, I'm going with.
Do you think it matters?
I think it matters in that I'm trying to really feel where there's disorganization in tissue. And you will feel that if you're running parallel to the tissue and all of a sudden it's disorganized and you have that fibrosis underneath, you feel that resonate through the tool. And then you can isolate it down with the smaller tool and you're getting that micro trauma in there. You're getting blood flow into that tissue. And then you follow it up immediately with exercise so that you're encouraging tissue realignment.
Okay. So that's the first thing you do. Mm-hmm. Then you do therapeutic exercise, then you do some type of exercise. What does tissue realignment really mean?
It just means that, you're just getting that connective tissue to lay better, right?
Okay.
You're getting that fascia to just lay better in line with the muscles and tendons underneath.
Okay. Is it possible for the skeptics in the room that you're simply increasing blood flow? Or is there evidence that you're actually changing the orientation of their fibers?
So you're absolutely getting blood flow in there. If you're not doing exercise after or loading that tissue in the pattern that you want the tissue to get stronger in, there's no way that you're getting tissue reorganization. So to do a treatment like that at the end of your session would make no sense. But when you do that, you should feel a change. Like I feel, especially with our population, I used to not be able to feel it as well because I treated in a clinic that didn't have, as healthy of individuals. Mm-hmm. I had people with more comorbidities that maybe they were chronic smokers. In that population, you're not going to get a tissue change. It doesn't happen. But in our population who is otherwise pretty healthy and have pretty healthy habits, that tissue does get stronger and healthier, and you can feel the difference in the tool.
Okay. How do you determine whether you want to go the ASTEM route or whether you want to go dry needling?
Dry needling, I'm going to use more for my tiny tendons. So I might use both. But a lot for those tiny tendons, I'm going to throw the needles in. I'm going to hook it up to stim. I'm going to get that perpetual twitch out of the muscle. And that's going to get synovial fluid to the tendon, right? Because our tendons have health from two sources. We have the blood flow where it's closer to the muscle origin, and you have the synovial fluid where it's closer to the insertion at the bone. And so you want to hit both. If the blood flow is not working, get the synovial fluid going by using the dry needling with the stim and just getting that glide of the tendon to get that synovial fluid there.
Okay. That makes some sense to me. And I like that you're willing to do both. When did you add needling to your repertoire?
When I came to True Sports.
Okay. So you added the needling and now you find that you can use it sometimes individually, sometimes at the same time.
Yeah.
Not at the same time, but in the same treatment.
I will say in the same treatment, what I have found is if I do needling first, if I have somebody who gets really sore and achy from needling, if I do the needling and then I follow it with some deep tissue work, they're a lot happier after the treatment.
That and to me, that just supports the idea that everything we're doing, whether it be cupping, needling, or Graston, it sounds like a blood flow game. Massage too, right? Because if you're going to increase blood flow to that tissue, it's going to A, warm them, B, bring in whatever healing factors there are. So it'll kind of set you up for a successful session. So that makes a lot of sense. Let's talk a little bit from 10,000 feet. What's the number one mistake you see runners make?
Overtraining.
Okay, they just go ham.
Yeah.
Okay, and so how do you address that? You get someone who's trying to cram in their marathon training, right, to a shorter period of time. How do you coach them out of that?
Yeah, it's hard to convince people that less is more, but really getting that rest is so important for the body, and it's usually folks that I have who aren't actually having rest days in their training cycle. Those rest days are just so important for that muscle recovery and tissue recovery. And so, I try to convince them to back off a little bit. I try to let them know that they're still going to do well. I've heard plenty of stories about folks who have gotten injured and they weren't allowed to run for a couple of weeks because of an arm injury or something, and they end up doing better in their race because they were forced to take time off.
Gotcha. Okay, so that makes a lot of sense. What type of metric do you use for readiness to train? Do you encourage them to get a Whoop band? Any biometrics you look at? Do you ask them to check their resting heart rate?
So I don't do that as much. I am very conscious of people's overall stress levels and overall loads, meaning that it's not, I've had runners who come in and they're like, Mary, I followed my training plan to a T. I had my rest days and I still got injured. What the heck? And I'm like, well, you moved, you went through a breakup, your job was really stressful, you didn't sleep for 4 nights, and all these other factors in life that pile onto our patients, and they don't even realize that, oh yeah, that's taking something out of my body too, and being able to recognize that. So I really like RPE, rate of perceived exertion. I like having them when they write down their race. So now Garmin actually has the function in where it asks you, oh, how did that run feel?
Awesome.
What was your RPE at? Are you happy? Are you like dying? And it actually takes you through that. And so if you are wearing a wearable, you have that information. Plenty of my runners track in a journal. And so I'll have them write how they felt on their run, making sure that if they had a hard run, if it was hot outside, if they were completely wiped out, that they're rating that run, even if the mileage was less, to rate it higher, so that they know that they need to rest a little.
Yeah, I had this conversation with a football player earlier today where he said, man, I really got to get in better shape. I'm like, dude, you're in phenomenal shape. He said, training shape is so much different than competition shape. And so we were running sprints and we were doing it for time and we were doing change of direction for time and things like that. And so we don't realize how much more aggressive and how much more of a load and attacks that takes. I think that does support the wearables world as long as you can know how to manipulate, your inputs based on that. So I think there's huge value in there. Is Garmin your preferred? It's just what you use.
It's what I'm used to. It's what I use. I do think it's just a little bit more accessible to runners. I think it's priced a little bit better than some of the competition. And they've really marketed and really made their brand around running. And so a lot of the functions of the watch are really good for runners.
Geared towards that. Okay, cool. Talk to me about recovery. If the number one mistake that runners make is overtraining, how do you prescribe recovery days?
So yeah, so I definitely want true rest days, right? So we'll probably get into cross training at some point. I love people doing strength as well on top of it, but you need to have true rest days. So keeping it so that if you have a shorter run day, maybe that's when you're doing other activities as well, so that your day off from running isn't like, oh, I'm off from running, so I'm gonna do my spin class, and I'm gonna go for swim, and I'm gonna lift some weights because I'm not running today. It's my
Right.
rest day. That's not a rest day.
Okay, so you're an advocate for taking a full day off. Talk to me about that cross training world, since you brought that up. What do you think is most important for a runner to hit? How often are they in the weight room, and what are imperative moves they need to be doing in the weight room?
And so their timing of resistance training is going to be very different if it's early in their training cycle versus late towards their race, right? So we can increase our strength, and we can increase our endurance or speed or whatever our goal is for running, but we can't at some point one of them has to level off so that you can continue progressing on the other one. And so if you are progressing strength too late into a running training cycle, you're going to lose your capability of completing the race to the best of your ability. Early on, I want somebody at the gym doing resistance, like heavier load training and building strength in that first section block of their training schedule. So you're probably looking at like the first 4 weeks probably. And certainly if you have an off season, you can push yourself a little bit more. Not all runners have an off season. But I usually have them in the gym at that point 2 to 3 times a week. And then as their load gets higher with higher mileage, I have them back that off, and they're doing 1 to 2 times a week. And once they're at that phase, they're doing a lot lighter weight.
Okay. And what moves are they completing?
Oh yeah. So I'm having them do your foundational lifts, right? I want squats. I want deadlifts. Deadlifts are really good at improving speed. So heavier deadlifting can lead to improvement in speed. That's been shown. Lunges, yeah, all your foundational stuff, and then core.
Okay,
Yep.
so everything I just heard sounds sagittal plane focused. When do we get our athletes moving in the frontal plane, and how important is that?
Sure, and certainly with our runners, they're losing their form in frontal and transverse plane, right? It's the glute med that's our culprit. So incorporating that one-legged work, so one-legged deadlifts, one-legged squats, doing one-legged windmills where you're standing with one foot against the wall and rotating the upper body, doing anything to work in that frontal and transverse plane. That's how I'm challenging them mostly with that. Maybe, some side bridge, side plank, things like that too are nice.
Mary marches.
Yes.
Mary marches. We'll link to a video on Mary marches, which is the number one, I think, influence you've had on my treatment strategy is the Mary march. But okay, so that makes a lot of sense. So you're hitting them heavy in frontal plane. You're also using these compound movements like the squat, like the deadlift, focusing also on unilateral. So all that makes a lot of sense. One thing that I think is sorely lacking, correct me if I'm wrong, is training plyometrics. I think our bounce goes to hell. I think the culprits would be frontal plane weakness because they just live sagittal plane. So that'd be number one. Number two is their ability to produce bounce. So when do you put plyometric training in their program?
Sure. Well, I mean, once they demonstrate the strength that they have the ability to do it, because I have plenty of runners who come to me and their Achilles are on fire. A lot of my older runners, I should preface that, will come in and they'll have an Achilles that's just lit. They can't jump.
Right.
They've never jumped in their life, probably, or not to the degree that I want them to. And so I've really got to prep them for that, make sure that they have the strength, and then starting low and working up. Do
you keep plyometrics in competition season?
You can, yeah, but it's again, you're like what I call PT exercises in your plyometrics. I'm doing once a week. I don't need them doing it more than that.
Okay, and then
when they're later in training.
And if you put your strength and conditioning hat on, are you including plyometrics in that programming throughout their season?
Sure.
Okay, so you're not scared of that, even though they're getting so many repetitions of bounce when they train.
Right, because I'm not going to have them do so many repetitions as part of their program. Right?
Okay.
The program is going to, their plyometrics in the gym are going to be much shorter.
Okay.
I'm
That makes a lot
not
of sense.
having them do a ton of touches.
And that bleeds into what you said previously, which is as load ramps up running wise, you want to peel back on some of that load, strength and conditioning wise or load wise. Okay, so that makes a lot of sense. Hey guys, quick pause and a quick shout out to this new masterclass that we just launched here at True Sports Physical Therapy. Myself and Dr. Tim Stone put together a masterclass of ACL rehab, and we call it From Table to Turf. And the reason we call it that is because it's going to teach you exactly how to get your athlete all the way from post-op day one with the nitty-gritty of regaining all of that range of motion, with the tips and the tricks that we use here at True Sports Physical Therapy that gets our athletes better, faster, and stronger. And that's early. And then how do you progress that athlete all the way onto the field with a ball in their foot or a stick in their hand or whatever their sport is, and teach them how to accelerate, how to decel, how to change direction, and all the mechanics that go in there. What drills do we use to get our athletes exactly where they need to be back on the field and even better than before injury? And I want you to sign up for that class now. You can find it on our website. You can shoot us a direct message and just say, hey, send me the course. It's right now on sale, so make sure you sign up now. It is fully accredited to get you all of your continuing education hours. Sign up for the True Sports Masterclass ACL, From Table to Turf. Thanks, guys. If the number one mistake that runners make is overtraining, what is the number one mistake that PTs make when treating the runner?
So, and this is near and dear to my heart because, as you know, I co-founded a company to try to help physical therapists learn how to treat runners. And
Hold on. What's the name of that company? How do we find out about it?
Finish Line Seminars. And that's finishlineseminars.com. We have our next course coming up May 4th and 5th.
Sign up for that. Everyone listening to this should sign up for that at the same time they purchase our ACL course. But okay, so yes, what is your pet peeve?
So yeah, my pet peeve is that I've had so many runners come to me through the years, and I might be the fourth or fifth practitioner that they've come to. And thank God they haven't lost faith in the field of physical therapy yet by that point. But they come to me, I'm the first one to watch them run. Now, you know, if you had a CrossFitter come in and said that they got hurt squatting, you would never not watch them squat.
Yeah.
If a runner is getting hurt running, you need to watch them run. And if you're not comfortable watching them run, take a course, learn how to watch them run, or refer them to somebody in the community who knows how to do that.
Yeah, and not just watch them run, record them running,
Yes,
right? So you can analyze it appropriately. I think that's really good advice. I would also implore everyone listening to think about becoming an expert in the patient that's in front of you. And more oftentimes than not, those athletes are more of an expert than the therapist is. And that's not a problem as long as you're willing to learn from the patient in front of you. So grill the athlete on how often are they training? At least know the right questions to ask. How often are you in the gym? When is the race? What program are you following? Etc. Because oftentimes these athletes are so type A, they're going to have all these answers. Your job as the clinician is to simply put all of those puzzle pieces together so that it makes sense. Don't pretend you're more of an expert than your athlete. Learn from them. I think that creates a teamwork environment where you're working with your athlete as opposed to you're dictating to your athlete. I think that goes a long way. Did I miss anything on that?
No, that's perfect.
Oh, well, I learned from the best. Okay, let's move to, well, before we move to our Eric Cressay lightning round, let me ask you this. What do you think, if your analysis of an athlete, of a patient is so vastly different than 10 years ago, and you did a great job describing how it is different, what do you think the next tool you want to add is? Or what does your assessment look like in 10 years from now?
I think what's amazing is with some of the tech that's coming out and the fact that you have so much access to all this data, I think that's just going to keep compounding and is going to keep pushing us forward. Right now, we're using Dorsivy. Dorsivy is inertial measurement units that is measuring ground reaction force, ground contact time. It's allowed us to take our 2D video assessment and add another dimension to it so that we have a better understanding of what's happening with the patient in front of us.
Do me a favor, walk through what a dorsivia analysis looks like. How do you set it up? How long does it take?
It doesn't take long. So it's just putting these sensors on the shins in the right spot and having the patient run just as you would for their running analysis on the treadmill. There's a nice function where if you have somebody who's that person that it's not happening until mile 3, you can have them go run outside with them on it. It collects all the data from that run to show you what overall ground reaction force looked like, and tibial peak acceleration, again, ground contact time, things like that, so that you have that bigger picture. It's a really easy, quick setup.
Yeah. That's super cool. And so you can see a change when they start to get their symptoms and then report it back to them.
Yep.
Okay, I love that. That's really interesting. Do you think you have an understanding, or what do you wish you were able to measure on these athletes?
I wish that I had the ability to have a 3D analysis system for sure. I think it definitely it gives you so much more understanding of where the patient is in space. But those systems are very expensive and it's very time consuming to set up at the moment. That technology is coming far with AI. And so it's getting to the point where computers are starting to recognize the hip, the low back, pelvis, the knee, the ankle, and being able to differentiate that and spatially recognize that. And so that's amazing. And that technology is going to come a long way.
That's coming.
And that'll make a huge change in what we're able to see and treat and then change.
Yeah, that's super cool. Okay, little off the running topic, I think. I'd love to get your take on what you've learned being in private practice the last 10 years and kind of how that's been different than working in a hospital system. And how is it different than the field of physical therapy 20 years ago when you came out?
Yeah, that's a good question.
Hey, thanks. I didn't even write that one down.
So, 20 years ago coming out, I worked a little bit briefly in private practice, and it was a little bit of the, you wanted to get a little bit more high volume in. I'm very fortunate to work where I do, where I can treat one-on-one with my patient, that I feel that ideally I'm giving that attention to that patient that they deserve, especially for somebody with higher needs, higher goals to get out of therapy.
How high volume was it when you came out of school?
You're probably doing, 15 to 20 a day in an 8-hour. Yeah.
That sounds like hell.
Which is still, like, I feel like there's clinics that are more than that, right?
Yeah. When I came out, my last rotation in school, I worked in Manhattan. We didn't even have appointments. Patients would just show, and like that elevator door would open, and they would walk out, and it's like, okay, I guess I only had 3 minutes with that patient. Now I'm going to spend the next 5 with that, and I might get 25 because maybe the elevator door doesn't open, but maybe it does. So I think there's far fewer of those clinics, but I think you're right. I think 15 to 20 is the norm, and that freaking sucks. That sucks. Okay, so you went from there, and then...
So I went from that, and then I threw myself into outpatient in a hospital-based setting. I will say that as a newer grad at that point in time, I think what is really nice about that is you're surrounding yourself with a lot of people, and so you're working in this clinic that has a ton of physical therapists around, and so you can bounce so many ideas off of each other. And I was fortunate enough to work with a man, Anil Bave, who had years of experience and knowledge and was very well published. And I was able to learn a lot from him. So I did gain a lot from working in the hospital. It became a little bit monotonous. And
monotonous how?
You see a lot of the same patients over and over and over again. And so your brain kind of starts to not function. You're not thinking as much because everybody kind of looks the same and all the surgeries are the same. So you had that happen. And then the other side of it was with hospital bureaucracy, with a bigger corporation, it's harder to be able to pursue some of the goals that you want, right?
Yeah. So, what surprises you now being in private?
Now, loving that I have the ability to spend that one-on-one time with patients. However, as you know, I'm very involved with the American Physical Therapy Association, and I am currently the chair for the PAC for the state of Maryland. And we are fighting to be able to provide that quality care that we want to be able to provide. And it's really sad that outpatient private practice isn't more represented at the national level. Because there are such battles to be had with insurances cutting reimbursement, and obviously we all feel it. My copay is $50 a visit, so when I do have to have care, it costs a lot. And yeah, it's a lot on patients, and there's only a few people who are winning out of this, and they tend to be the people running the show at the insurance companies, and then obviously shareholders.
Yeah, it's not the patient, and it's definitely not the therapist. So what's your advice to PTs, the 3 PTs that are listening to this podcast? What's your advice to those 3 PTs, how we can change these reimbursement rates, or how we can change the profession for the better?
Yeah, so nothing's going to change if we don't speak up and let our voices be heard. And so if you're sitting in your office and you're complaining because you're seeing 20 patients a day, and you're only spending 10 minutes of time with them, and you have a tech who's doing all the rest, if that's your situation and you're just sitting in your office complaining about it, that's not doing anything. You need to get involved with the American Physical Therapy Association. That's our biggest lobbying body that we have. So doing that, and then talking to legislators and really getting comfortable with the idea and knowing who's my state. And it's really the state first, because we can make bigger changes at the state level versus federal.
Yeah.
And so getting to know who's your state senator, who are your delegates, things like that in the state of Maryland, really important. And those people want to hear from you. You vote for them, and that means a lot. And so if it comes from you and it comes from a personal experience, it goes a longer way.
This is such a naive question, but how do I find that information of who I should be talking to, how I get involved? Is that readily available on the APTA website?
I think there is a function on the APTA website that you can put in your zip code and find out who.
That should be the only thing on the APTA website.
If it's not on the APTA, I'll double check and make sure it's
put it
there.
on
And
there.
if it's not, it's going on there. But then you could go to your marylandstate.gov and find it that way too.
Okay. And if not, if all else fails, just email Mary at truesportspt.com.
And I'll find it.
Okay. Okay, good. Yeah. And figure that out for us. Okay. Ready? Lightning round.
Okay.
Quick answers. Who is the best running physical therapist on the planet?
I like Brian Heiderscheit.
Brian Heiderscheit, who's in?
University of Wisconsin.
And he taught you what?
He is a huge researcher at University of Wisconsin, and he is big on that overstride stuff. And I just love all the research that comes out from their department.
Okay. What do you wish new physical therapists knew coming out of school as it pertains to running analysis and the profession at large?
I think new physical therapists coming out, they need to know what running gait looks like, and they need to know what the muscles are doing during running. That I think would be hugely important in changing their practice for runners.
Did you learn that in graduate school?
No.
Neither did I, but it could have been I missed that class because of a Jewish holiday. But I wish schools were doing a better job of teaching this. And I would implore, just like you said, it's not enough to just sit around and bitch about it. Like, talk to your graduate schools and say, hey, I'm treating all these runners. Let me teach. Let me volunteer. Let me just get involved with your student population. I think that's one of the biggest impacts I've had on physical therapists, is just creating the student structure where students can come to us, because it's so hard to kick down the door of universities. But if you're a private practice owner, or if you're in private practice, make sure you're taking students, make sure you take educating those students properly. I think shout out to Christy Chiesa and to Rachel Noble here with True Sports, who have done an unbelievable job of spreading the net. And if you're listening to this podcast and you want to become a student, do a rotation at True Sports, hit us up. We would love to have you. We're going to have 30 students this year and probably 40 to 45 the following year. It's unbelievable. So the more we can do of that as a profession, and really that's why I started this freaking podcast, was to teach PTs what it's actually like to help athletes getting better. When rubber meets the road, how do you get these athletes better? It's not all in journals. It's actually has to do with the practice. So I think that's really good advice, and that's well-founded. What was your biggest surprise from your time lecturing in Qatar? Because I heard you went to Qatar to lecture a few years ago.
And it was before the pandemic. And so I would say the biggest surprise to me coming pre-COVID was talking to somebody in a burqa and actually seeing how much can be relayed through the eyes.
Yeah.
I had no idea.
Yeah. Why would you?
Right.
I loved that. I also loved being in that lecture hall, speaking to students and seeing young ladies in jeans and tank tops and in burqas sitting right next to each other. I thought that was fascinating. I also loved their willingness to learn. United States of America, is far ahead of what we were seeing PT wise in Qatar. But their eagerness for the profession, just like that you have, I thought was eye opening.
And the hospitality.
And the fish and the hookah was unbelievable. So I highly encourage a trip to Qatar if you got time for it. Okay, where is Dr. Mary Miller in 5 years from now?
Hopefully, I am giving conferences and lectures all around the country with Finish Line seminars.
Hell yeah.
Or as an adjunct professor at some university.
Well, I feel like there's going to be a long line of universities coming out of this podcast. Just tell us, because you did a great job of highlighting some of your successes, getting patients better, like we always do in these conversations. What was the biggest mistake you made clinically, and what did you learn from it?
Yeah, biggest mistake I made was I had a colleague come to me who was a runner, and they couldn't figure out what was wrong with them. They were having some hip pain, and it was after soccer or after a run. Wasn't every step pain, and I missed a stress injury. It was stress injury of the femoral neck. And it was a person who is, obviously very knowledgeable, very healthy, and they had energy deficiency, and not on purpose. It wasn't like they were starving themselves or anything like that, but the amount that they were doing was more than the energy that they were consuming.
And so how does that color your interactions now?
Whenever I have a vague hip, like vague groin, inner hip, or deep buttock, if I have that come through the door and all my tests are negative and I can't figure out what's going on, I usually am referring to a sports med doc to get it checked out.
Yeah, well, that's an awesome lesson. And I think even to take it a step further, because God knows I've made that same mistake as well, it's developing a network around you. Like if I'm working in Fells treating a runner and I have something like that, I know that, hey, Mary's an expert at this. Let me have Mary take a look. Or what physician, who is the sports med physician that is going to listen to you and is going to respond to your email? You have to have done that legwork prior, because otherwise you're out on your own and you're liable to possibly make a mistake like that, like we all have. So it's great to hear that you kind of learned from that. Okay, bringing it to a close, any tidbits of information that you want to get out to all of our listeners, and then also just remind us how we get in touch with you, how we find out about Finish Line.
Yeah, definitely, if anyone is interested in treating runners, you can reach out to me at mary@truesportspt.com. And if you want to take the extra dive into Con Ed, you can go to finishlineseminars.com and find out our upcoming courses. We have a 2-day course that's all taking the runner from the start to the finish, called Going the Distance. And we take you through all the subjective nuances that you need to know, objective, and then taking it through that treatment and gait retraining to get them to the finish line. And then we have another course called the Female Runner from Start to Finish. And so really looking at the lifespan of the female runner and how that's different from our regular running population, just because of certainly around postpartum years, and also with some of the energy deficiency stuff that's big in the female runner community, and then all the way through menopause into the later years. So
much to learn. That's really awesome. Thank you for joining us. Thank you for the years of tutelage. You've made me a better physical therapist, which wasn't hard. So I appreciate that. And thanks for all you've given to the running community. This was awesome. Thank you so much for the knowledge. Thank you to everyone listening. If you want to find out more about what we got going on, check us out on Instagram, True Sports PT. And then if there are other experts, a number of you guys wanted to hear about running injuries. Obviously not my forte, which is why we brought the expert in, Dr. Mary Miller. But hit us up, DM us. Just let us know what you want to hear. We're here for you. And this family, this True Sports family, is growing like crazy, and we're always looking to add in-house talent. So if you want to work in a clinic like this, shoot us a DM. We'd love to consider you. We got an awesome interview process and a great, really working environment of team of outstanding professionals like Dr. Mary. So don't be a stranger. Thanks for listening, guys. Bye-bye. Thank you so much for listening to the True Sports Physical Therapy podcast. Thank you for your support. We really appreciate it. You can find us on Apple Podcasts, Google, Spotify, wherever it is you consume your pods. We are there. Please give us a listen, share it with your friends, share it with your colleagues, leave us a 5-star review. And as always, give us a follow on Instagram, on TikTok, where we are posting constantly daily content on how to be an outstanding sports physical therapist. We appreciate you guys. We can't wait to hear from you.